We're going to get started. Hi, everybody. My name is Inbal Shacham. I am honored to be here today to talk a little bit about the work that we've been doing at St. Louis University and the Geospatial Institute at the GeoHealth Lab that I am leading. I am really excited to talk about some of the work we've been doing, and I brought some colleagues along with me. So we're going to kind of do a whirlwind and hopefully have enough time for conversation. And so Reza Tourani is an assistant professor in the Department of Computer Science, and Stephen Strogan's a PhD student finishing up at some point and very soon in the College for Public Health and Social Justice. And again, I'm Inbal Shacham. I'm a professor in College for Public Health and Social Justice and the Associate Director of the Geospatial Institute. So we were asked to come and talk at Venture Cafe, and I love the idea to get some feedback from people who are not our typical audience. I always love that. So I wanted to give you some ideas about what we've been doing, and I want you to know that in no way is this a comprehensive list. So today we're going to focus on one part, but really we are in general talking about from the virus to the satellite. So our colleagues and the Vaccine Center are focusing on developing testing methods, vaccine development, as well as treatment, successful treatment for COVID-19. So we're excited to work in partnership with them, and lots of the work that we do at the Geospatial Institute really builds on what they do, and we're trying to partner better together. Today, we're going to talk about some of the work that we've been doing specifically about smartphone data. But in general, we are using technology and data to improve understanding about how COVID-19, well, in general, we talk about this lots of time, and pre-COVID-19, we've been talking about this. But the work that we've been doing has been specific to COVID-19 and looking at how it's such a location-driven infection. We're seeing patterns that we expected, really, just the movement from urban centers to our rural areas, that we want to understand the vulnerable populations, or particularly vulnerable populations, and how do we better understand, predict, and respond to their needs. So we're going to talk a couple different ways. We have developed a symptom tracking app. It's called My COVID-19 Tracker, and we're going to talk about how we've used anonymized smartphone data for community mobility measures. And in there, we're going to talk about the idea of data sharing and privacy in this really complicated space. Just a note of housekeeping, just before I forget, we are going to take questions at the end. So these are really, the discussions today are really centered around each other. So at the end, I will somehow be able to manage question and answer. So if you drop them in the chat, that would be helpful. So another team of faculty and staff have been working on developing My COVID-19 Tracker. It's really will be available to both Android and iOS. We developed it in both. We are focused on getting this out as a symptom tracker or a symptom monitor. It's a way and a method to help. It's not the answer. There is no one answer. So we wanted to be able to leverage the data that we understand how to collect and technology to build it on what our healthcare infrastructure is using and traditional public health efforts. So we are trying to roll this out as soon as possible. We've been held up a little bit with our Apple and Google stores, but we will push on through. We're working through it. The purpose of the app really, and I'm guessing you've seen lots of apps like this, but really to measure intraday measures of COVID-19 symptoms. We anticipate that symptoms change throughout the day. So if you're monitoring how a person is managing their infection, or if they're becoming symptomatic. So we want to be able to say, okay, in the morning you felt like this, in the evening you felt like this, and are there changes or important changes that should be monitored to healthcare or public health or employees. We also want to be able to track in locations where individuals have been, so that they are able to, we're able to report back and say, okay, this area may have, if a symptomatic user or somebody who turns positive is in that location, we want to be able to inform the location and say that there was an exposure and an increase of risk of COVID. We also have these geofencing opportunities where we're letting people know where their nearby clinics are, where infections are currently. So using specifically data that's scraped from Hopkins primarily, but really saying this is our real-time infection, our management of those locations. So as you're walking into a space, you'll know, or going into a new county, you'll know about the rate of the infection of COVID infection. So you can prepare and use preventative measures as needed or as appropriate. So I said there's morning and afternoon. They're identical, so they're really focusing on symptoms that CDC has endorsed. These are the symptoms that are, it's like a checklist, yes, no. We want to ask each of the symptoms so that we understand there are different, the spectrum of the disease is very unclear still. I think that, this many months into the pandemic, we still don't have a full understanding and range of exactly how people are experiencing the infection. So we want to be able to measure this and say, okay, this person is likely to get sick, and how shall we help them? In the evening report we push out is a survey about, did you go out in public? Did you encounter, about how big of a size of the public have you encountered, and did you use masks? So this is like I talked about the geofencing location. So this is the use precautions, but we can also use it internationally. We translate it in Spanish and Italian. We can translate it elsewhere if the opportunity arises and the need. The contact tracing, I'm going to let Reza talk about, but really we're wanting to leverage this type of technology to help public health.
Thanks, Ambol. Hello, everyone. This is Reza Rahani. So as one of the features that we are recently...
Reza, we can't hear you. Hold on. Don't know why either.
Can't you hear me now? Can you hear me now?
I can hear you.
Oh, okay. So, okay. Back to it. So one of the features that we recently started working on that is contact tracing. Probably all of you know about the contact tracing. The goal of contact tracing is basically informing the user if they have been actually in the close proximity of a COVID-19 positive case, usually in the period of the 2 weeks. So this application is not going to be really hard to build if you are considering a backend server that basically all the users send their location every few minutes to this backend server. The server can basically look at the proximity of the user's location, and if the person with the COVID positive have been found, the location that has been allocated or stored in the server can be matched against the location of other user, and then the presumably positive users can be informed that they have an encounter with a COVID positive case. But the problem with that is users have to constantly upload their location to a backend server, and that is one of the problems that have been arises across the globe with a lot of countries. So this is not something that we want. User wants privacy. If we have to give up our location, history showed us that we are not really willing to do that. Now, for that reason, a good contact tracing application basically shouldn't allow all the data to be uploaded to a backend cloud. Should basically store the data, most of the data on the user device in the locality of the user. That's one of the features that such an application need to provide. The other one is if the data is going to be shared, at least that data shouldn't be provide linkability between different aspects of the user. Maybe only the anonymized location of the user need to be shared, but shouldn't be linked to the user identity, email address, or phone number. And the third property is basically data minimization, which is now in line with the GDPR regulation in Europe, that basically if we only need the anonymized user location, we shouldn't really share anything beyond that. We should minimize the amount of data that we are sharing just for the purpose of the application. Now, there are a set of applications that actually have been proposed using Bluetooth mechanism to avoid sharing all the information with the backend server. How it works is when two users come into each other's proximity, they basically have the smartphone application running on their device in the background of the operating system. So these applications using the Bluetooth technology, which is only used for close proximity communication in the order of a few feet. So this application basically generates some randomized token and then share this randomized token with each other if the encounter is more than 10 to 15 minutes. Now, this is a good thing because this randomized token doesn't really store information particular to a user, but actually show the encounter of two particular users. Now, to avoid linkability of the data, this randomized token should be changed over time. And there are studies suggest that in the order of 15 minutes, so half an hour, the randomized token should be changed. Now, if you look at the slide on the right side, you can see that these keys are basically those randomized tokens that can be changed every few seconds. Can go to the next slide, please. So these tokens that users share with each other will be stored locally. And that is one of the premise of this decentralized contact tracing application. It means that the user don't need to share those, even the token, even if they don't have any information about user, they don't need to be shared with the backend server. How does it work? As you can see in the figure 3, if the user is diagnosed with COVID positive, with the user consent, those randomized tokens that the user collected over the course of the last 14 days will be uploaded to a backend server. Now, these tokens are the one that user either collected or the user shared with other user. Again, they don't have any particular information about the other user of the application. It's just talking about different encounters that the user had in the past 2 weeks. Now, with this information, and again, this is going to happen with the user consent. Definitely, if the user doesn't want to do that, we can avoid sharing those information. Now that the backend cloud have all this information, all the token, periodically, other users are going to download a database of these tokens from the backend cloud. And then they download this database. They're going to match every single token against the one that they stored locally that basically represent their encounters. If there is a match between the set of the token they downloaded from the server versus the one that they stored locally, it means that the user, particularly the user in the yellow shirt in this case, have been in a close proximity of one user that has been diagnosed with COVID-19, which is basically the user in the blue shirt. And that basically indicates that maybe this user have to take further step, contact the health authorities and follow up on that case. This approach basically satisfies the 3 properties that we want, because most of the information will be stored on the user device. Basically, users store the token locally. Only COVID positive user have to, if they're willing to, they can share their tokens with the backend cloud. So which means local storage information. Unlinkability is provided because users keep changing their tokens. So there is no linkability between 2 different tokens. These are totally randomized, cryptographically generated. And then the minimization of data is provided because unless a COVID positive case has been diagnosed, the user don't need to basically share their information. And even in that case, they don't need to share all the information, just the relevant anonymized information. The only caveat in this case is how should we avoid some malicious user that we all know that might happen, falsely claiming they are infected with the virus, and basically they're trying to overload the system, moving across the city, collecting a bunch of tokens with their encounter that they had with other people, and at the end of the day, uploading all those to the system, just to maliciously polluting the system, saying that everyone now that have my token are probably COVID positive. It can have some negative impact on the hospitals and all those things. This is the part that basically need some help from the health authority. So in this case, users shouldn't be able to directly upload their tokens, even if they are COVID positive, unless a health authority, whether a doctor, a nurse, or a first responder are collaborating, users shouldn't be able to do that. Although mechanism can be designed to reduce the amount of work a doctor needs to do or a nurse needs to do to help the user upload the information, it can be easily in form of getting a voucher from the doctor, in form of QR code or anything like that to minimize the impact on the doctors, but still need some help from the health authorities. So with that one, I will hand over to Steve.
I'm actually stealing a moment back. So in the context of what Reza was talking about and thinking about privacy, one of the studies that we did early on in the as the pandemic hit in the region, we in mid-March, we studied and collected data on about 800 participants across the country. They're nationally representative of the population of the country. And what we found, we wanted to know is how willing people were to share their geospatial location during the time of COVID. So thinking about if they had symptoms, if they had if they were diagnosed, and if they wanted other people to do that as well. So what we categorized them as a community, we categorized them into community work. Would you be willing to share your data with community or work, friends or family, and government in general? And I will say, to my surprise, 70% agreed to share location data if they were symptomatic or positive with government. A little less so with the other categories, but specifically, they wanted others to share also if they were positive. And this was earlier in the climate around what we were doing and what we were willing to do. So I think it was early in the conversation. The other piece that I wanted to highlight is that it was regardless of sociodemographic characteristics, whether and across age. So age, race, gender, education, and their political leaning. Everyone, 70% of the people strongly agreed that they wanted to share their private data. So that actually gave me a lot of promise, thinking when data can be shared for good. So with that, I think this is a really also important piece that we can contribute. Steve, you can take over.
Awesome, thank you so much. I'm Steve Scroggins. I work with Inbal Shakam at St. Louis University at the College of Public Health and for the Geospatial Institute. We have been really lucky in our situation that our research team was asked to join or was invited to join a national collaborative that uses panel marketing data on foot traffic across the country, and I think even a little expanding outside that. Normally this has been used for marketing purposes with some research applications, but since the current pandemic, it's been a very, very strong source, and so many public health sociologists, bio researchers have been using kind of this data source to contextualize, frame, and identify information. And what it is, it's aggregated movement of individuals using smartphone data. So similar to what Inbal had been talking about with her application. They aggregate this data down to the census block level and follow it for some time. This data has all been anonymized and standardized, so not being able to identify individuals or anything like that. But we've used this data to help better inform our regional COVID task force to look at how agency and adherence to these stay-at-home policies change and develop over time and location. We've also, from this data, have found that a lot of that adherence, a lot of the ability to stay at home is driven by employment, specifically occupation type. So normally, I think classically, when we think about essential employees, it's always been emergency preparedness workers, law enforcement, those kind of that immediate frontline workers. And I really think that over the last, or we now know over the last 2 or 3 months, that's really changed within our zeitgeist. That essential worker now has come to include grocery store employees, employees at public transportation organizations. It's come to include healthcare support workers and So that's beyond just ER docs or physician. That also includes nursing assistants or individuals working at nursing homes. So we've found that a lot of this data and a lot of those changes are driving community mobility, how these communities move and interact. And I think more recently, what we've also found out through using this data, leveraging this data, is kind of intersections. And one of the, I think, most interesting intersections that we've looked at have been the leisure and protest intersection. So I think a lot of people will probably recall Memorial Day weekend. I know it was on CNN. A lot of national news organizations picked it up. We had a big rush to Lake of the Ozarks Memorial Day weekend. And then I think the week after that, we had protests. So we had these two really important and really large scale geographical movements occurring in the middle of a pandemic. So we wanted to explore that further. We wanted to make sure that that information and make sure that analysis got to people who drive that policy, who develop that policy. So I'm excited to share a couple of the maps I think, we made. Awesome. So this is one where we wanted to look at zip code. Anyone familiar with government or local state government data? They love zip codes. And anyone who's familiar with geographical analysis knows that a zip code is really just a made up thing by a post office. So luckily, integrating different data sources using HUD crosswalk data, things like that, we're able to aggregate the data that we had access to into zip codes to kind of build and estimate what a zip code looks like. So this map, this figure here, is a spatial autocorrelation of individuals, the daily average of individuals staying home through clusters. So a lot of that's just words that maybe we're not super familiar with, and that's totally okay. Because what it really means is those red spots are spots where the percentage of people staying home is really high. And the blue spots are percentages or areas or clusters where the percentages of people staying home is really low. And we can see, so the first thing I think that's interesting is that divide between the county and the city stays consistent. A week before the local, the St. Louis County and St. Louis City stay-at-home orders were put into place, all the way to a week after. That divide is pretty consistent, where we have the city, especially North City, staying home less than swaths of St. Louis County, mostly all the way up to West County. I think another interesting thing about this, was it's cyclical, right? So if we look at week one or week before, and then the week after, the clusters have matched back up. That people were staying home, but as soon as that order ended, people went back out, right back out. And I think a lot of, we know that a lot of medical providers, a lot of public health agencies were hoping that just the fact that implementation, that policy was there would drive people to stay home just a little bit more. And now we know from the data that it really didn't. As soon as it ended, people were going back to restaurants, going back to work, some by choice, some by requirement. And that distinction is also really important. Sorry, next man. So this is similar to the first map, but an aggregate of the entire time period. So similar what we see, West St. Louis County and St. Louis City, those are the census tracts within 305 census tracts from March 13th to May 25th, 2020. So what we see is, again, similar to the first ones. The individuals who are staying home more tend to be into Southwest County. Individuals not staying home less tend to be St. Louis City. what's interesting, and what I think we kind of lose with that first map, is we have those two clusters at the top that are switched, right? So we have North City staying home a little bit more, and we have North County, which is staying home a little bit less. Interesting, those that staying home a little less for North County, I don't know if I can, oh, I can't see it. That census tract up there is part of a zip code area where COVID rates were especially high for a really long time. I think one of the highest in the St. Louis region. So contextualizing this, making sure that people know that this is occurring, using and integrating different data sources to kind of figure this out is extremely important. So this is stay-at-home adherence. Oh, sorry. So this was an example of an integration that we did with our staying at home, with our adherence metrics to those social policies, and employment type. So I mentioned earlier that how important food service was, how we've identified that that's an occupation that is absolutely could be considered an essential worker, that while places are shutting down, reducing hours, things like that, food service workers, food preparation workers are still going to work and still have to leave the house to travel to work. We also, I don't think it's any coincidence, but I think it's very important to know that these tend to be hourly paid, low wage jobs, right? So putting the most vulnerable people out front and not letting them have the resources to prevent and protect. I'm hoping that this data will push to make those changes. But with this specifically, what we can see, and we can see that legend down at the bottom, again, similarly, tells you what's happening in these different tracks, what's happening in these locations. So those red locations are areas where food employment, the percent of residents who are working in food is high, and the percent who are traveling to work is also high. So we can use this to better identify areas where maybe interventions are needed. Right. So maybe we can say like, well, specifically in this area, the food workers, they're not traveling a lot. Maybe they work close to home, or maybe they are able to work reduced hours, things like that, as opposed to areas where we can see in North St. Louis City, downtown, Central West End, those food service, those residents who are working in food service locations there are traveling for work. They're leaving work and going other places. And this is just an example. So we've done this with healthcare support workers, important to mention, healthcare support workers. We've done this with individuals working in business management, office administration, maintenance, different Bureau of Labor Statistics, job categories, to see how these patterns overlap and combine to find areas of extremely high risk due to employment. So this is a map that we devised from the Lake of the Ozarks and protest location, and I smile because I feel like the findings are extremely significant and extremely important. Putting this together and calculating this was one of, I think, the biggest challenges that I've faced in my academic career. So I'm just, when I see it, it's like a picture of my child. I think it's really important. So what we see here, we're identifying places of origin of where individuals who went to Lake of the Ozarks on Memorial Day weekend, and overlapping them with individuals who went to two protest locations the week after Memorial Day weekend, right? So these are individuals who traveled to a location where there's absolutely guaranteed to be crowds. We had talked about it earlier, and that I think it's pretty safe to assume no one goes to Lake of the Ozarks to isolate themselves. Maybe camping in other spots, but luckily with this data that we've integrated and we've leveraged, we don't have to really assume that. We can look at locations and devise hypotheses based off of what's the closest business, what's the closest attraction, things like that. So what we're seeing are areas that absolutely overlapped. So we're seeing these this orange area, these swaths of North County into a little bit of North City. So those are areas where the residents had low areas of low percent traveling to Lake of the Ozarks, but had high percent of going to protests. And as we move towards St. Louis County and St. Charles County, excuse me, is also up there, we see those patterns again change. So again, I think easy to see the divide between the county and the city populations. Geographically, mobility wise, I think that's an important thing to mention. But we do see a high percent, those blue and greens, intertwine and intertangle together. So these are communities that are right next to each other, but have different mobilities, but because of the places that they've gone, are sharing risks. So saying that like, well, I mean, I didn't go to Lake of the Ozarks, or I didn't go here, or I didn't go here. So what we're seeing is that your neighbors did though. And that's a really important distinction, because we know that in geography and geospatial studies, that space matters, and the space that you share with others matters. And I think this pandemic is going to define that so much more for us. It's going to highlight it for us. So being able to share this information and this analysis with the COVID task force, with other researchers, with healthcare physicians and organizations and agencies is going to be and is something that I think we're in Ball and I are, Dr. Schock and I are so lucky to be able to do, that we're hoping and getting to see that it informs some changes.
Thanks, Steve. I would just add that the other piece I like to think about with that analysis is that there were 5 census tracts census blocks, okay, that had both, and that had both high movement to protests and to Lake of the Ozarks from our region. I think that's important for us to note. And then secondly, I think there's the privilege of leisure, and what we do with that label, and understanding there is risk. Now, I will say that was conducted, those analyses are important to contribute, but the movement of COVID in our communities is different. And just as protests have grown throughout our communities in ways that expanded beyond the geographic regions of the first week of protests, we have lots more people who have lots more access to protesting and to continued and different experiences in leisure with our increased rates throughout the whole state and the country. You know, I think we have lots of other projects we're working on. We have a lot of communication strategy efforts that are really growing. And one of the pieces is, if we do get a vaccine, and when we do get a vaccine, how are we going to communicate its effectiveness, its efficacy, and how do we convince people to for the uptake? You know, there's going to be different portions of the population that are most interested and most vulnerable of not getting it. You know, so getting the vaccine, how do we convince people, the right populations, to get the vaccine? Steve highlighted some of the work we're doing about informing policy and policy interventions. I think that these health inequities we've been studying for a long time. The spatial inequities have been specifically interesting to our groups. One of the pieces that we see with COVID-19 is that we just amplify the speed and the impact in our communities that need more help. I think I'm guessing without much hesitation that our rural communities are going to be more in need than they expected previously. So with that, I kind of want to close our presentation piece up and then consider, A, here are ways to reach us, B, any conversation, any questions, thoughts,